Marisha.
Hey, you take a
So, Christopher Tlape,
Yeah.
I simulate no.
Yeah.
From primary school, seems like you knew how to go on so. But I think we're not a doctor, but what you're doing right now is too close to being a doctor.
Sure.
So, monate, like a pharmacist.
Yeah, thanks, my brother. Josie, when being every professional has the pros and cons, the benefits and the disadvantages. So for pharmacists, for example, for me, what I love the most about it is more interactive in terms of patient interaction. You meet patients at face value. You see a patient there, and then they come and explain to you, I've got 1, 2, 3 challenge. And most of the time, we are in a position where we can be able to assist these people at a fraction of the price that we have otherwise paid if they were to go to a doctor. So I feel like we're doing a very important job in that sense. The patients are able to get the benefit that they would have otherwise gotten to go doctor, but they come into us, they get the same, if not better, service at a cheaper price. And then the disadvantage, what I would say, is that oftentimes in our industry,
It's a disadvantage. It's only the good
no advantage. You remember what I said is that the patients are benefiting.
Sure.
So I feel that's an advantage. We are able to affect
advantage
them more
for the patients or way.
for both, because never impact satisfaction of helping people. Saying somebody getting better for me is the ultimate goal. That's what I'm saying. For me, it's the ultimate goal. The advantage is for the patient more, but obviously what is good for the patient is also good for me by virtue of being in the healthcare space that I'm in. So disadvantage, I would say, like a clear disadvantage would be, oftentimes we are understaffed in the pharmacy industry because we don't have enough staff, so the pharmacists and pharmacy personnel. I feel like, if we can motivate more young kids, because it's a beautiful profession. I remember when I was in matric, I went to ask someone, one of the pharmacists at the time, if they would guide me, career guidance in terms of this career path. And that guy was like, no, but don't follow it. There's no money. That's the only thing he kept saying. Don't follow it, there's no money.
Pharmacist,
that's what he said. That's what I'm saying. I'm like, you know what, doc? Somebody once told me, the money comes. Put in the work, the money will come. So in any industry, I feel like that same ethos is relevant. You must always have that mindset, or the money will come. The money will never be enough, even if you earn 100,000 a month, it's still not enough. You get $1 million a month, it's still not enough. So if you want to make money motivation, then it's going to be a problem. So since I was a kid, I always wanted, for the health, medicine.
I
wanted to do medicine, too much.
When I envy that because of when you knew what you wanted. And
I don't take that for granted. I know it's not an easy thing.
Sure.
I know people who did medicine to 5th year and left medicine and go to study political science. There's one girl who studied political science from varsity. She did it up to 5th year and she left it.
Because it was not.
The Basari were forcing her. And it's not like she was not capable. You can see she went to 5th year. She was almost done. She was done, but she said, no, this is not what I want to follow. So that's what I'm saying. Don't take it for granted.
Marwena, how did you know? Because most of it was when how did you know I wanted to be this? You did young, like
my character, I always based it on the interactive nature of my character. I feel like I'm a very interactive person, and I like seeing people happy. I'm not to say I want to please people, but I like to heal people. I like to be part of the solution. And I always aligned to biology at school. So I loved the science of how the human body works and how the life works. So that thing, coupled with my compassion and empathy for people, I feel like it was an obvious choice for me because of the character that I was as a kid. And like I said, from growing up, it was from the get-go. I even dabbled in nursing at some point. So everything was healthcare related. And it had nothing to do with the money, because there is no money in healthcare. It's just a matter of you're able to live comfortable. Not to say you're going to get rich or anything like that.
But there's wealth in health. No,
100%. That wealth is 100% there. But some people come in with a mindset that I'm going to drive a Range Rover with a Porsche. Those things, they will come, but normally if you are just, I mean, obviously you have to do other things more than just being in healthcare. You can be in healthcare maybe in other capacities. Maybe, let's say, your business, you're tendering with the department.
Sure.
You can make big bucks to buy those cars.
Sure.
But if you're going to be like an employee or healthy, you can never be wealthy from that. You can be comfortable, which I think a lot of people are, in terms of you don't go out to sleep with an empty stomach. Your kids are able to go to school.
So, yaanong ke ha se kopane situation ile gore ke la tsama go tlogela le traumatized mo go ne healthcare ona lo ne towards batho.
Sure.
Or kopana le tsone ke buy in such or I can pick up a wine.
And I don't even see them as traumatizing. That's the thing. You know? I don't even see them as traumatizing. Because I'm trying to think of one scenario that I would say was, but yeah. Look, there was one time that I was very overwhelmed. I was not traumatized. I was very irritated.
Sure.
One patient came to the pharmacy and he became very unruly. He was ungovernable. He became very rude. And I was very angry. The industry.
Gore kopane mathata a batho ba ntsi nna ke batla go itse via di diseases gore bona gore mare hemon go tla gore motho ne le bolwetse jo bo yana
Sure.
ke one the trauma side ke batla go pick up gore motho wa ntle go diragetseng gore a eletsana le such thing wa tlhaloganya. You one time said something ka yadi mare yaanong ke tlabe ke disclose dilo tsa batho mo
Everybody can take the scenario. What's the scenario?
Scenario sa gore se sengwe sa gay yaanong ke lo ntlela ka scenario sa gay.
Right. Yeah, that's another. Yeah, that one was very funny. It was very traumatizing. You are right. It's one of those. You know what? But actually, I have another one that was worse than that one.
Sure.
I'll get to that gay one before. Maybe people who are listening, they'll say we are homophobic. And we are not.
Sure.
But I will talk about the issue where I encountered an old man who was raped, gang raped.
Yo!
I was working in Rustenburg in Lidach at Moses Kodan Hospital.
Sure.
There was this old man, 94 years of age, man. He came in at post-exposure prophylaxis. These 3 or 4 boys raped this guy. Yeah, they raped him, and there was a time this hunger was starting to come into our townships and our locations, our villages. So I don't know what possessed those boys to do that, but those boys raped that old man. That was for me the worst I've seen so far in terms of the industry that we are in. I was helping that gentleman, and not knowing how do you know, because he's old, man. He probably doesn't understand what I'm saying. The way you sounded like he's staying alone even in the house, you know. Those type of things. It was very terrible.
Mare ke ipotsa what goes through a mind ya motho
That's it,
gore
bro.
go ripa monna yo a tsofetseng.
It's demonic, you know. Those are demonic things. The demonic spirits, they control those people. I don't know.
Speaking of demonics, go na le a se kopane le a situation whereby motho o tlhoka thuso ne, but I ke itse ra khona go ba lemoga batho ba cause I don't know gore ba tla khona go ba lemoga whereby motho a lwala mara a khona go kry-a medication ono gore khona go mo thusa from bolwetse ba gagwe. We need to find out gore it's spiritual matters. A o tlhola kopana batho ba gore ba na le di spiritual matters instead of health matters.
No, there was one patient, and I don't remember her scenario per se, but I remember the patient was struggling with healing, and she kept coming back, you know. So because I would not say I'm conversant with spirituality in terms of the spiritual realms. I would be able to see if somebody needs spiritual intervention. I wouldn't know that, but this patient kept coming back, and I kept giving her different things, and she was not getting better. She would go to doctors. You know, a lot of my patients will come to me and say, "You talk about doctor," and he did not help me. So sometimes when I say, "Okay, I can't give you antibiotic because you need a prescription. Go to a doctor." She's like, "No, I've been to a doctor and he's not helping me. You're my last hope." So most of the time, people come to us as a first option, not as a last option. So this one was coming as a last option. So that was something. And you know what? That lady never came back to tell me if she came alright. And I told her to seek, alternative assistance. I don't tell somebody to go see a sangoma or a spiritual healer. No, I just say alternative, interventions. What you make of it is on to you in terms of which alternative intervention you are looking at. More profita or naka or whatever. So it's not a lot of cases that I've seen. I just had one like that where I felt like this patient's need is beyond my capabilities, you know.
Sure.
It's beyond medical capabilities. She needs, you know, more supernatural powers or assistance, something like that.
Sure.
You know, you always tell people, you must always come back to your core, what your core beliefs are. You know, whether you believe in Sangomas or you believe in your ancestors, you believe in your pastor, you don't take anything for granted in terms of your belief system.
Sure.
It's very powerful.
Sure.
So I just told them, you know what, try to align yourself to your spirituality. Maybe you can get assistance. But I don't know whatever became of that woman, because I was not very close to her like friends. As a client, she would come and, you know.
Black or white or yellow
No,
colored?
no, black. 90% of my clients are black, so black.
So warla shota di pharmacist things.
Yeah, we are very much short.
Warla shota. Nung planning gore rona. When we grow up, re khone go nne pharmacist le dirang and again ene kare I want to be the career exhibition
You are right.
next ne
The problem with our profession is that it's a very timid profession. People in the profession are very timid. They are not aggressive people. We often people refer to us as people who take instructions. We follow instructions.
Sure.
We don't lead industries, you know. Like, you know, the doctors, they will always assume position of power whenever they are in a group of people.
Sure.
So our industry, in general terms, is a very timid one. People who are in our profession, they are followers, they are not leaders. So that's why we find ourselves being disadvantaged. For example, I will take a classic example. Doctors for many years able to dispense medication. Remember, a doctor prescribes, a pharmacist dispenses.
Sure.
So now, a couple of years back, there was a bill passed where the doctors can dispense from their own practices, meaning that the patient doesn't need to go to the pharmacy. You see the doctor, he prescribes and gives you the medication there. So now, last year or 2 years back, we fought the same fight with the Health Professional Council of South Africa and South African Pharmacy Council.
Sure.
But we also want to be able to prescribe, because ourselves, we prescribe up to a certain schedule.
Sure.
So medication is scheduled to, from schedule 0 to schedule 6. So now we are allowed to prescribe up to schedule 2 by virtue of being professional pharmacists.
Kana ona ranga tla ke kopa medication depression.
You can't, because the law doesn't allow me to prescribe for you as a pharmacist.
Sure.
So what we fought, the fight that we fought, actually we won the case sometime last year where we are able to prescribe up to schedule 4. So there's a course that we do as pharmacists after qualifying. Yeah, you go to Portugal University. The course is something like is patient drug initiated therapy that you do up to a higher schedule, like up to schedule 4. What it means is that as a pharmacist, I'm able to diagnose you with diabetes or high blood pressure and put you on medication. I don't have to wait for a doctor to prescribe for you. So you come in, I do my tests, my 3 separate tests, and I convince myself based on these tests.
Sure.
This patient is suffering from high blood pressure.
Sure.
Or this patient has got TB or whatever. After doing a few tests. So up to a certain schedule. You know, most of the time we deal with what we call primary healthcare therapy or treatment. So what it means is that we will prescribe like a NESCO clinic. So our
Mari, okay, before we continue,
that's a difficult one, because you have to, for me to say that, I have to link it to the NQF level. So NQF level in pharmacy, I believe is 9, and I believe in university 7. Professional nurse.
Sure.
So I'll say we are based on the NQF level, not anything else. Some people, they will say they are above people based on social standings. I like to base it on so that it doesn't sound like I'm being pompous or anything.
Yeah,
we have to base it on scientific fact.
Sure.
So this scientific fact is a biometric decided by the department or a national qualification framework of a certain degree. Is this amount of a PhD, of a professor, you know, those terms. So based on that, yes, we are above nurses. Yeah.
Sure.
So, but adding to what I was just saying, we are now able to prescribe up to schedule 4 and treat clinic level patients.
I get like pretend as if you got schedule 4.
Drugs. So basically, drug scheduling of drugs. So the higher the scheduling, the more the safety profile needs to be observed. The more
yeah, like a schedule is
6. So 60 cells are codeine, those drugs that are Very, very, like body heroin, for example,
Sure.
in narcotics, drugs like body opioids, where you take about body pethidine, very strong painkillers.
Sure.
Some people use them to drug themselves and use them for recreational purposes. When, for example, something with an element of heroin within
So I'm
what they're
getting
mixing.
nyaupe ke do tse di tswa mo di doctor then malite ba find out or okay that means banana ke like it can knowledge tswa mo di doctor
Yeah,
then malite ba capitalize ka yona.
I wouldn't say the doctor, but just scientific people. So basically, this investigation,
So it's just that means what the game it's a scientific experiment went wrong.
Exactly, I would say that. Because when you're paying a drug called efavirenz. So that drug is what was used in the past to treat people who want first-line treatment of HIV and AIDS.
Sure.
It's not used anymore. So for example, now I'll talk about my own experience. I once had a guy who approached me to assist him with efavirenz so he can make nyaupe. So he was offering me loads of money to be involved in the syndicate of destroying small kids. And I refused to, I cannot be party to this. Because our brothers and sisters are now becoming, the invalid because of this scourge of putting nyaupe and whatnot.
Sure.
So they would mix it. I think they're saying red poison and efavirenz, but I know those are two basic components. I don't know what else they're adding these days. But that drug, this thing called hallucinogenic. So what it means is that you have nightmares. So you take that drug and you sleep, you have nightmares. It's the way in which it works. It's a central nervous acting drug. So you will have nightmares automatically by taking that drug. You'll see things just like when you are smoking.
Hallucination.
That's it. That's why they call it a hallucinogenic. When you take it, body drug to turn about tiki, for example, there are a couple of them where you start seeing things. Even some people have reported hallucinating. So those are type of problems that we are trying to address with this matter.
So what we wanna this is for depression. Okay, sharp. What causes depression?
Yo. So
now I would say okay from my side,
sure.
Depression I'm not sure, but I'm thinking already comparison ya social media.
Sure.
Social media ever since it didn't thing, but was started about depressed.
Right.
So I'm thinking already depression because you're okay sharp. Chrissy only phela life is you ke be ke sheba life ya life ya my correspond la Chris
100%.
then ke begin depressed,
100%.
feeling worthless. So I know from your medical side
100%. Yeah, so when you look at a depressed patient, for example, when you take their bloods, because we take bloods when we're dealing with people in psychiatric hospitals and whatnot.
Sure.
So there's a hormone in your body called dopamine.
Sure.
It's called a happy hormone.
Oh yeah.
So that dopamine is released by a couple of reasons. It can be released by a drug, it can be released by experience, social experiences, just a feeling of happiness. So some of these people, they become addicted to these drugs because they release dopamine. They make you feel better.
Sure.
So when you have got dopamine levels being high, because of whatever reason, you become happy. But if something happens that suppresses that dopamine, so now I'm not talking about experiences of seeing people, comparing yourself to people.
Sure.
You can be depressed by pathological depression, where you are depressed based on either a disease or some chemical that's altering your release of dopamine.
Sure.
So if a chemical you take blocks the release of your dopamine, you could be the richest person or the most successful person, but you'll still be depressed. But now it's a medical depression because it's based on pathology. It's based on chemical release that is altered by either a structural damage, maybe you were in an accident, something happens and destroys part of your brain area that produces dopamine.
Sure.
You will have a problem because you will be depressed.
Sure.
Or something that happens that releases a lot of this dopamine. You're always feeling happy. It's also like that's why they call it. Some people have got bipolar. Bipolar, you have got this manic and depressive states. So your hormone levels are extreme. You have an extreme release of dopamine. You have an extreme suppression of dopamine. So you are feeling two different extremes at a time. So most people who are normal, they've got a balance between the two.
Sure.
But those who are abnormal, then they have got bipolar. You are 1 minute so happy, the very next minute you are so the saddest person. So what you explain is 100% true in terms of the experiences and comparison and whatnot. But you also look at this other part where it has nothing to do with experiences, just got everything to do with chemical release and the way in which your brain neurotransmission is happening, activities in your brain, and then these affect the way that you release these hormones.
So I totally your chemical release you. I totally somebody said I'm to having sex.
Right.
Le partner ha wa attract another basadi kan tlinga gore basadi ka ba khona go sensa ke one dopamine or game when it comes to sexual terms. Because motho sa having sex I agree wanyana.
That one I don't have any information on that one. Yeah. I've heard of stories like that, but for me they make no sense. Yeah, scientifically they make no sense because you can talk about pheromones where you are releasing certain aromas. When you got these aromas that are attractive to certain sexes, like the opposite sex, for example. So, but that is not a medically proven fact. It's something that it's an assumption that people have when you have a girlfriend, girls start to want you, and when you don't have a girlfriend,
but something to say release man happy and
that's why you must Google that thing. There's this thing they call them pheromones. But these pheromones are the conclusion is not a conclusive evidence. These are some of the things that we are talking about in terms of not really assumptions that happen in science. It's one of the assumptions. It's not a conclusive evidence that thing. You can, for example, you can't measure those pheromones because there's no part in your body that releases those things. In terms of center of the brain, let's say for example, center of the brain that releases neurotransmitters. So you got dopamine. Dopamine is a happy hormone. It doesn't become like exuberant to a patient or to another sex so that they become attracted to you. That one is, like I'm saying, for give you assumptions, it's a science. And it's something that I do not have any experience on. I've heard people talking about those things, but yeah, it's one of those admissions that we cannot overrule, nor can I admit to.
Kaya gore mona motho mona wa tla celebrate mona gore mona I return from the desert when you go sokola.
See, that's the assumptions that we're talking about. That's what I'm saying. Scientific assumptions,
Ya mona the mental health, what's happening in mental health? Na ke tlhaloganya.
Yeah.
I get tlhaloganya ro thwa again when it comes to mental health. Ke utlwa batho ba bua there's a campaign about mental health. There's a lot of mental health. What's happening?
So that one, my brother, is a very sore aspect of our nation. As you know, the suicide rate in South Africa is among the highest.
Yeah.
And the suicide rate dominates within men. So men mental health is, I think, the focus should be on that. And most of the mental health campaigns are focusing on men because men are more likely to commit suicide than women.
But what causes that?
You see, mental health, you're looking at a lot of different aspects of. Most of the time, people talk about mental health as in being depression. Depression is the flagship. It's not necessarily the only thing.
I can't differentiate between
the two. So the thing is, mental health, because it's synonymous with depression. For example, I will say, most of people, when they have got HIV, the assumption is that they will have TB. That's also true, synonymous. It's a synonymous assumption.
Sure.
So same thing with mental health. Because people don't dwell on a lot of other mental conditions. Mental health is only seen as depression. And it's not the only one,
Sure.
Like for example, psychosis is a mental health, a form of mental health. That bipolar is a form of mental health.
Sure.
There's this thing called personality disorders, where you call about narcissists, you're talking about people who think it's a mental health.
Sure.
But because we got special focus on a particular type, which is depression, that kills a lot of our people.
The narcissistic mental health.
It's a mental health, a form of mental health. It's not normal. You cannot. No, they are not okay. There's treatment for that. They are not fine. It's a mental condition.
Is it?
Exactly. Because the opposite of a narcissist is somebody who's always doubting themselves, always saying, "Can you are a narcissist? You think you are better than everybody else?" So the opposite of that is being the most depressed person around. Again, it gravitates towards depression because depression is just a general term that we tend to think of it. when somebody has got a mental health. Even somebody when they are psychotic,
Sure.
they get a sense of depression at some point because you see them on their own and in a little corner and whatnot. So that one in terms of by definition, like I said, it's just any state of your mind that is abnormal. Anything outside normality. So within your mind space.
Sure.
So you're talking again, not always refer to chemicals and neurotransmitters, those things I talk about in terms of low levels of this, high levels of that. For me, I always try to make sense of it in that way. Because when you are talking about behavior of a human being, you're talking to psychologists, psychiatrists, you are measuring behavior based on observation. So you observe somebody, you go to a psychiatric ward and you come to a patient, I'm observing behavior. What is this person doing?
No,
No, I'm not saying that.
no, like the way we're going to with the health aids.
No,
What's all like advertise you for something, then what about it? I will be like,
Right.
I'll get my way.
Right.
I'll try to get a take. Somebody want to get you. So then I go, I need to check myself somehow.
100%. 100%.
Christopher Tlape.
My dog.
Bruh, I hope this is not for the first and the last time.
Respect.
No, never touch the basis. Never do me this affair. So I know there's a lot of it. I know there's a lot.
Too much.
In closing, what do you want to say?
Generally,
you
are taking it one day at a time, man. Sometimes I feel like we put too much pressure on ourselves, and that eventually leads us to a lot of mental problems.
Sure.
Because we always, we for a certain age, I'm supposed to be married. I'm supposed to have kids now. I'm supposed to be this. I'm supposed to be that.
Sure.
Always think about it as what. We all are running in our own lanes. We're gonna get there eventually. When somebody got there before you, you will also get there eventually. The aim is to just keep going.
Sure.
Once you keep going, that's all that matters. And don't worry about getting there fast. Worry more about going in the right direction. Sometimes we run too fast in the wrong direction. That wastes our time. Because when we get to the wrong destination, we're going to revert back to the right one. So because we are too worried about the speed as opposed to the direction.
Yeah.
Let's worry more about the directions. And when you're in the right direction, whether you're working at a snail pace or what's the slowest animal in the world?
I can say it's
kudu. Yeah, so that one.
Yeah.
So you don't want to be running like a cheetah in the wrong direction.
Sure.
Rather walk like a kudu in the right direction. That's it, man. That's really my word of advice, my parting way.
No, thanks a lot.
Respect it. Let's do this, dog. Let's do this.
Each other.
Give me a second.